Hello, everyone, and welcome to the rheumatology practice session so that you can have the answers to questions in rheumatology that you can be asked as you rotate through the department. And also, as you want to get to know a bit more about rheumatology, and this will be useful for you to be aware of the way to tackle and approach these questions. So, without much ado, the question we will start with is a 39-year-old woman with rheumatoid arthritis. She's admitted to hospital with a hot, swollen, and painful right knee. Which of the following is the most important blood test? So first option, CRP. Second option is full blood count. Option C is liver function test. Option D is blood culture. Option E is uric acid. Now, the answer here is blood cultures. There are two most important tests you can do for someone with a diagnosis of septic arthritis, which this will be, because a single swollen joint is a septic joint until otherwise proven. You want to do a blood culture rather, as soon as possible. You want to aspirate that joint and send it off for microscopy, culture, and sensitivity. All the other tests, whilst they are useful, they are not specifically tackling the problem. So the assumption is that this lady with rheumatoid arthritis has a diagnosis of septic arthritis, which you should consider for every case of a single swollen joint. Question 2. These are images. Now the question is, which is the best statement about rheumatoid nodules? Option A, they indicate severe disease. Option B, they are often excised. Option C, they cause severe pain. Option D, the histology is non-specific. Option E, they are frequently present at diagnosis. Now, the best answer is A. They indicate severe disease. The presence of nodules on either the elbow or in the lung or on the hand is indicative of seropositive disease. What that means is the patients with nodules often indicates that they're positive for rheumatoid factor antibodies or anti-CCP antibodies. And you can also have nodules in the lung, as I earlier mentioned. If found on the lung either via chest x-ray or CT scan, it is important that those patients are evaluated thoroughly to ensure that it's not cancer. You can't always assume that every nodule in the lung is a rheumatoid nodule, but rheumatoid nodules tend to be well-defined and circular, unlike cancer nodules that do not look as well-defined and well-circumscribed. But speak to a respiratory physician if you are not sure, which is how we manage that in real practice. 21-year-old man had an attack of urethritis 7 days ago. He now has a swollen left ankle and a painful right knee. He also has bilateral conjunctivitis. Now, which statement about this arthritis is true? Option A, it's likely to be rapidly destructive. Option B, it's likely to resolve within 6 months. Option C, it will spread to involved hand joints. Option D, does not respond to NSAIDs. Option E, doxycycline is ineffective. Now, the diagnosis here is that this is a reactive arthritis. And once you know that the diagnosis is a reactive arthritis, the best answer is option B. It's likely to resolve in 6 months, because the prognosis of reactive arthritis is that most cases will resolve in about 6 months. Some cases can extend to about a year or 18 months, but for the most part, most will resolve. Sometimes these patients need an anti-inflammatory, sometimes they need disease-modifying therapy, but for the most part, most cases will have settled in about 18 months to 2 years. Question 4. A man is referred to rheumatology clinic with back pain. Which of the features below would most make you think of a diagnosis of ankylosing spondylitis? Now, option A, age of 49 years and below, you should say. Option B, rapid onset over the last 2 weeks. Option C, symptoms are made worse by exercise. Option D, pain at night and first thing in the morning. Option E, loss of thoracic kyphosis. So I'll pause just to give you some time to think about the answer. D is the best answer because pain at night and first in the morning suggest an inflammatory pain. And morning and night stiffness is typical of inflammatory pain. To those that are aware, there's a nice mnemonic for inflammatory pain, and it's eye pain, where I is insidious onset, pain is P is pain at rest, A is age less than 40, although this man is not exactly less than 40, but it's around the 40 mark. I is improves with exercise, N is night pain. Any of these features should make you think of an inflammatory back pain. So the answer here is D, as I mentioned. Question 5. What is the most common cause of dactylitis? Now, option A, rheumatoid arthritis. Option B, joint hypermobility. Option C, psoriatic arthritis. Option D, reactive arthritis. Option E, ankylosing spondylitis. Now, there's a picture at the bottom right corner showing you dactylitis affecting both his feet in the third and fourth toes bilaterally. The best answer here is option C. Dactylitis, whilst it can be seen in ankylosing spondylitis and reactive arthritis and psoriatic arthritis, by far the most common diagnosis with dactylitis is psoriatic arthritis. It's worth mentioning that it can also be seen in gout and also it can be seen in sarcoidosis as well. Worth mentioning. Next question. 48-year-old man has a 20-year history of back pain, has had some improvement with naproxen. Which drug should be offered next? So option A is ethambutol, option B, methotrexate, option C, sulfasalazine, option D, hydroxychloroquine, option E, TNF inhibitor. Now, think about it. E is the best answer, and that's in line with guidance. We tend not to use conventional synthetic DMARDs for ankylosing spondylitis. It just simply doesn't work. So once the patient has failed 2 anti-inflammatories, in this case, oftentimes the patient would have had an anti-inflammatory with the GP in some sense. And you can see the option does not contain having another anti-inflammatory. So you should naturally progress to anti-TNF, TNF inhibitor, option E. Next question. 63-year-old man is diagnosed with acute polyarticular gout. Once the attack settles, he starts taking allopurinol 300 milligrams daily and continues with diclofenac 50 milligrams 3 times a day with lansoprazole. He's reviewed 4 weeks later. What is the correct statement regarding his allopurinol treatment? Option A should be reduced to 200 milligrams daily. Option B should be increased to 400 milligrams daily. Option C should be left unchanged. Option D, the drug should be stopped and swapped for colchicine. Option E, it should be titrated according to the serum urate level. Now, because he's already on allopurinol, it doesn't need to be stopped and it doesn't need to be increased. What needs to happen appropriately is that the allopurinol needs to be titrated to serum level of the urate. And when you're treating gout, we're aiming for a urate of under 360 micromoles per liter. A good way to remember this, and I tell this to patients in clinic, is that when you get very bad gout, it makes your world go round. So 360 is the magic number. Option E is therefore the best answer here. Question 8. 36-year-old woman with rheumatoid arthritis starts treatment with methotrexate. What's the best advice? Option A, take the tablet every day. Option B, do not worry about getting pregnant on the drug. Option C, there's no need for blood monitoring tests. Option D, nausea is the most common side effect. Option E, methotrexate has multiple drug interactions. Pause for a while. D is the best answer. Nausea is the most common side effect because option A is wrong. Methotrexate is taken every week. Option B is wrong because contraception is absolutely pivotal in young women because getting pregnant on the drug would mean there's a chance that the fetus has a problem with congenital malformations, and we don't want that. C is inaccurate because we do blood monitoring. D is therefore the most common answer. Methotrexate does not have multiple drug interactions. It has interactions with certain antibiotics, for example, septrin, antibiotics that contain a trimethoprim group is a problem for methotrexate. So hence, we're going to start UTI type antibiotics. You need to ensure that you do avoid the use of trimethoprim in patients on methotrexate and give them something else like nitrofurantoin. Question 9, 52-year-old man has a 10-year history of hand pain and he has developed swelling in his fingers that are often red and very painful. What is the diagnosis here? Option A, is this rheumatoid arthritis? Option B, is this reactive arthritis? Option C, is this psoriatic arthritis? Option D, is this gout? Option E, is this septic arthritis? Pause for a while. The picture is fairly typical. This is gout, and this is a typical picture of a tophi. You can see some areas of white just underneath the skin. That's what gives it away. It's not pus. The history, fact that it's 10 years, red and very painful, that gives it away that it can't be a septic arthritis. This is a gout. Option D. RA doesn't affect the distant phalangeal joints. That should also give it away. So it can't be RA. It can't be psoriatic arthritis because there are no nail changes and there's no psoriasis anywhere in the question. Final question for this particular video, which is part 1, is a 46-year-old woman presents with a 7-month history of low mood, widespread pain to joints, muscles, and unrefreshed sleep. What's the most useful test? Option A, is it anti-CCP antibodies? Option B, is it an ANA, that's anti-nuclear antibody test? Option C, is it C-reactive protein? Option D, is it thyroid function test? Option E, vitamin D. The balanced answer here is you must do a thyroid function test because these symptoms are typical of hypothyroidism. And because that is potentially correctable, you want to do that. Now, vitamin D is important to do, but a low vitamin D is not going to cause immediate problems. But a low thyroid, if not corrected, will cause problems. So you have to exclude low thyroid, you have to exclude low calcium or high calcium. Yes, some vitamin D, but because underactive thyroid states can